Welcome once again to the telecast of recording of colorectal session in Indo-UK SURGICON 2020. I'm sure you have enjoyed the recordings of this session. We tried our best to cover the colorectal part in a very short span, and we were very, very fortunate to have speakers from all over the world. In fact, people who have some great work in their fields. And to start with, our first session was expert talks, and in that we have 4 talks: surgical challenges in diverticular disease. This was taken by Neil Smart from UK, and he very beautifully elaborated the problems of diverticular disease and how do we manage them. And as we know that diverticular disease sometimes can be very complicated, and surgical indications are only in cases where there are complications like perforation, abscesses, bleed, stricture, etc. And most of the times it is either 2-stage or 3-stage surgery. Chances of complications in the surgeries are higher as compared to other colorectal procedures because of the fibrosis and because of the inflammation. And sometimes to prevent the ureteric injuries, we need to stent the ureter, or we need to put the illuminating stents in the ureter. And sometimes diverticular disease is widespread in throughout the colon, but we don't have to treat it. We only need to treat the diverticulitis part, or if we can identify the bleeding segment, we need to remove that segment. But if we feel that patient is having recurrent problem, and if you are not sure about the segment which is causing the problem of where the bleed is from, then of course we need to do a subtotal colectomy. Now, that was a very nice lecture. And the next lecture was by Dr. Anil Harul, who talked about quality of life issues after anterior resection. As we know, that anterior resection syndrome is a huge problem after low anterior resection, and we require a dedicated team to look into the symptoms and to really evaluate what really are the symptoms. And very small things like digital evacuation or enemas can solve these problems. But the message is that we must have a dedicated team to look after these kind of patients. Then we had Professor Joel Leroy from France, and he talked about transanal approaches of rectal cancer. And as we know that transanal approach is a novel approach, is a recent approach. It has not yet established completely, but it seems that this approach is here to stay, though at this point of time, complication rate, especially the urethral injuries are more common after transanal approaches to these kind of cancer. But as we know that any new technology and technique takes time to settle down, and probably this seems like, according to Professor Leroy, the technique for future. Then we had Dr. Aswin D'Souza from Tata Memorial, who talked about pushing the boundaries in locally advanced rectal cancers, and he really gave a very fascinating talk. He talked about how pelvic exenteration, anterior and posterior, how chemotherapy, how resurgeries in these patients is possible. But a word of caution that all these surgeries should be done in a center who is doing high volume work, who has a good team, and who has a multidisciplinary teams. Then we had free paper sessions, some very interesting papers. Dr. Taha Sheikh from Gangaram Hospital, he did talk about how stomas should be made, what are the complications, and one should not take stomas lightly, because that is something, sometimes the stomas can be, permanent. We think they are temporary, but they can be permanent. So how do we cite them? How do we avoid complications? All this stuff. Then there were 2 very interesting papers about leiomyosarcoma of the anorectum and a cecal duplication cyst, which was again very, very much appreciated. Then another interesting paper was gastrointestinal stroma tumor of the pararectal area, again very well appreciated. Then we had a multidisciplinary panel discussion on rectal cancer. This was moderated by me, and then we were very fortunate to have Professor Gina Brown from UK, who all of us know, who invented and did a Mercury trial and showed us the importance of MRI in pre-staging, pre-surgery and post-radiation stages. In this, we had Dr. Surupa Mitra as a radiation oncologist from Rajiv Gandhi Hospital, Delhi, then Dr. Sharad from UK, Dr. Mohammad Abdullah from Bangladesh, And we really discussed the challenges in the management of low rectal cancer, like, how distal, how far can we go, what are the indications of neoadjuvant treatment in our country, whether stoma should be formed, whether drain should be kept, and MRI, how MRI helps us in staging, and how MRI has really changed how we treat rectal cancer. So this was again a very fascinating panel discussion, and we really enjoyed it, and which was very, very informative. Then we had talks by Dr. Parul Shukla from New York, and he talked about the role of laparoscopy in low rectal cancer and in favor of laparoscopy. Then it was again refuted by Professor Chung from Korea. He talked about robotic surgery. So there was a very interesting discussion on whether robotic is better or laparoscopy is better. And the inference was that it does not matter which technique you use. Robotic definitely may have certain advantages, but whether it can be applied widely to all segments of patients in all cases is obviously debatable. So again, a very interesting discussion. Another important point which we discussed in panel discussion was whether a PET-CT is required for all rectal cancer cases. It is not required, it is not recommended unless there is a high clinical suspicion. But a lot of times in our clinical practice, because we require CT chest, CT abdomen, we in a tertiary center like ours, most of the times patient is referred to us with a PET scan in hand. But otherwise, it is not recommended unless there is a clinical suspicion. And once you do a PET scan, you should always follow up with the PET scan. That's another point. So friends, I think overall it was a very, very interesting session, very informative session. And I am very sure and I really hope that you enjoyed this telecast. I would also take this opportunity to invite all of you on behalf of IHS and Team Coimbatore in May to come for the annual conference of IHS, which is being held in Coimbatore. The Team Coimbatore is working really very, very hard to make this a successful event and a very, very informative event for people who are going to be present there. This is probably going to be the first physical big conference of IHS after the COVID lockdown. And I hope by that time, all of us will be vaccinated and we can really join that meeting and meet each other for fellowship. Not only it will be an academic feast, it will also be a platform where we can interact socially after a very, very long time. So with these words, I really hope that you enjoyed today's session, and I really hope to see you in Coimbatore, and all the best. Thank you very much.
Indo-UK SURGICON. As I said, there are a lot of things are increasingly common. As you can see, the two buildings you see there, one in the Mysore, I'm sure Professor Griffin will find out the UK.
Are there any questions for me now?
Projecting here. So there are a lot of things beyond the buildings and beyond the personalities, beyond our joint venture for the welfare of our mankind. So with that, we'll bring in the Vice President from Royal College of Edinburgh, the son of the soil, actually one of my senior from Chennai, and Paula Rajesh is there to speak on the guidelines-based surgical practice. And to do the honors, we have the senior personalities from our end, from IHS, Dr. John Thanakumar, our Chief Advisor from the IHS, from Coimbatore, and he is actually a trainer of the trainer. And we have none other than Professor Hegemanton Udwadia, as you know him from the big morning. He is our father of our laparoscopy. Like we have both the father of endoscopy, laparoscopy listening now, and he is with us and able to join today in this August gathering. And of course, your other personality. I think it is like a family function. You have Mr. Rowan Parks also saying hello to you, the Vice President of Royal College. So they are going to chair the session for this talk, and also to say and introduce this speaker of today. I request our Vice President Rowan Parks, his colleague, whether he is kind enough to say words, and I think I have already sent the citation. If he is able to have that a copy, or he can read from there. And this is the citation we have made for especially for Paula, and you will be receiving it soon. And you can keep it proudly on the table, and will be. And also, this is the citation we are about to read, and the honors are on behalf of the IHS, the whole EC, and all the 8,000 members of IHS. Or thank you for having joined here. Over to you. And I request now Rowan Parks, can you? Yeah, yes, sir.
Yeah, well, good day, everyone. My privilege to join you, and what I've heard so far today has been absolutely fantastic. So, congratulations! And it's also my huge privilege to introduce my friend and good colleague, Mr. Pala Rajesh. So, Mr. President of IEGAS and the Royal College of Surgeons of Edinburgh, it's a great honour to introduce Mr. Pala Babu Rajesh from Birmingham, UK, who has been chosen to deliver the Indo-UK SURGICON 2020 Oration in the IAGES and the Royal College of Surgeons of Edinburgh Collaborative Conference. Mr. Pala Rajesh graduated from Madras Medical College and moved subsequently to the United Kingdom to pursue his higher surgical training. He obtained intercollegiate FRCS in cardiothoracic surgery during the year 1994 and travelled to the US and Far East to learn and teach the art and science of thoracic surgery. He returned to Birmingham in 1995 as the lead consultant in the Department of Thoracic Surgery and established the specialty of physio-assisted thoracic surgery. He performed more than 5,000 procedures, including scores of video-assisted lobectomies, lung volume reduction surgery, and sympathectomy. Mr. Rajesh conducted many higher surgical training courses in thoracic surgery. He has been elected as a regional training program director for cardiothoracic surgery in the West Midlands Deanery and is regional specialist advisor to the Royal College of Surgeons. He has dozens of publications in peer-reviewed journals to his credit and has delivered many lectures across the globe. He was a council member of the Royal College of Surgeons of Edinburgh from 2012 to 2017, and also of the European Association for Cardiothoracic Surgery from 2015 to 2018. He is currently the Vice President of the Royal College of Surgeons of Edinburgh, and he's the first person of Indian origin to be elected as Vice President in the 515-year history of the Royal College. President, sirs, it's a great honour and privilege to present before you Mr. Pala Rajesh for delivering the first Indo-UK SURGICON 2020 oration on guideline-based surgical practice on this day, the 15th of October, 2020. Thank you.
Thank you, Mr. Parks. Let us go and listen to Mr. Pala Rajesh give his oration. Can you unmute? Yes, sir.
Thank you very much for those kind words, Rowan. I owe you one, and as soon as I come to Edinburgh, I shall share that with you. I'd like to thank Professor Michael Griffin for his talk previously, and as usual, I have to follow him. I'd like to take this opportunity to thank IAGES for giving me this honor of presenting on this first Indo-UK SURGICON 2020. I would like to personally thank Professor Raman Goyal, Professor Pavnendra Lal, and Ishwar from my hometown, who has behind the scenes done a hell of a lot of work, and I have been hearing about this. I would like to share my screen now. Thank you. Now, I was requested to speak on surgical guidelines, but then I called Pavan to find out whether he meant surgical guidelines in general or whether it was regarding impact of COVID to the surgical guidelines in the United Kingdom. So we decided that we will talk about the impact of COVID-19 on surgical practice in the UK. Now, how did the UK government respond to this pandemic? We realized that there was something going on in early January. There were 2 Chinese students who returned from Wuhan to the University of York, and they were in hospital with the virus. Subsequently, we also got to hear about a businessman who had attended a conference in Singapore in February, and after his return to the United Kingdom, went on holiday to ski in Austria. He came back, and there was a surge of infections with all of the members in the ski chalet. In March, the government was aware of an increasing number of infections in the district of Lombardy in northern Italy. This was the time that the Prime Minister felt that something needed to be done. This was in mid-March. However, he didn't take a decision, according to some, early enough to start thinking about a lockdown. So the first mantra that went out on a lectern from the PM's bulletins was stay at home, protect the National Health Service, and save lives. Towards the 3rd week of March, we had the lockdown. The N.H.S went into preparation. The Public Health England, along with the SAGE, who are scientific advisors in the UK with relation to emergencies, group were put together. There were daily bulletins from the Chief Medical Officer, the scientific advisor, and ministers. The college was involved with those discussions to advise the Chief Medical Officer. Then the N.H.S response was immediately to deploy staff to the front lines. Rapid training was given to all of these people. Trainee workforce were also now deployed along with the consultant workforce. And then we realized that we had a procurement crisis in the country, and we had to get PPE from overseas. The first consignment arrived from Turkey, and we found that they did not adhere to the regulations. So we had a problem. So what were the surgeons tasked with? The surgeons were tasked by N.H.S England and the Royal College of Surgeons of England to look at the way that services should be delivered and training should also be delivered. However, the training bit, I'm not going to talk about. It's a subject for another time. And these guidelines were put together in a collaborative manner. The people who were involved were all of the 4 surgical colleges and the 10 specialty associations in the United Kingdom. The use of personal protective equipment was discussed. This was found to be mandatory. The way that the delivery should be carried out in the ward areas, in the admission areas, in the accident and emergency departments, the endoscopy units where diagnostic and therapeutic endoscopy was carried out, at the operating theater, and in the intensive care units. So, next step, non-essential surgery was stopped. What was deemed non-essential was left to the trusts and the consultant, the clinical leads of various specialties and the consultant body. Emergency surgery carried on. A COVID test was done on all of these patients on admission. However, surgery was carried out as it was a life and death situation. The acute surgery patients who came in, a history was taken so that they found whether they had an exposure to COVID or not. They were tested for COVID. A chest X-ray was taken. And if the patient came in with an acute abdomen, then a CT abdomen was carried out and at the same time, if it was possible, a CT chest was done in order to make sure that there were no infiltrates in the lungs. As far as urgent planned surgery were concerned, patients were phoned to their residences and asked to self-isolate for 14 days. They had to be COVID negative. And as Mike alluded to earlier on in his talk, informed consent was extremely important. The probability of COVID after surgery was discussed along with its adverse events with the patients and the family. Aerosol generating procedures were considered high risk. This include the dentists, ENT surgeons, anesthetists who were intubating patients in intensive care and also during induction for general anesthesia. Now, this group, even in intensive care units, had to have full PPE. This was mandatory. This consisted of having disposable gloves, fluid repellent gowns, and eye face protection or FFP23 masks. It was important to practice the donning of PPE prior to a procedure. So the practice of donning and doffing was carried out, and this was essentially for the safety of the patient and the healthcare professionals who are delivering healthcare. Laparoscopy was considered to be a high-risk procedure. In the initial stages, it was felt that it should be only carried out if it was mandatory. If an open procedure was an alternative, it should probably be done. However, as experience went on during this COVID crisis, they continued to carry out laparoscopy, but there's careful deflation after procedures. Filters and traps for suction devices were continued to be utilized in a safe manner. So again, common sense, safety first approach was to protect the staff and patients. Then the guidelines for surgery was set by the FSSA along with all the four surgical protocols. The guidelines cover all the studies except obstetrics and gynecology, ophthalmology, their own colleges, and it was said that it shouldn't be done for the Royal College of Surgery. So prioritization was done in 4 levels. Level 1 was subdivided into 2. Level 1A was emergency, where the operative procedure should be carried out within 24 hours, and it was a life and death situation. Level B was urgent operative procedures, where the procedure could be carried out within 72 hours. Level 2 was surgery, which could be deferred for up to 4 weeks, which is probably a month. And level 3 was surgery, which could be delayed up to 3 months. And level 4 was surgery could give us a view with which we could run the services in the United Kingdom. It was a strategy for planning. It allowed the hospital managers to plan allocation of resources, individual surgical specialties to appreciate the need of the other specialties when operating resources were limited. If there were various specialties with few operating theaters available on the day, whether we could then work out a way in which we could allocate operating time to the appropriate specialty with the need. And it also facilitated the development of regional surgical networks to deliver surgery in a timely fashion. So patients presented either with mild disease or with severe disease, and a substantial number were asymptomatic. So this was a disease which we were learning about on a daily basis with dynamic changes. Now, the UK primary care teams felt that if the patient had mild to moderate symptoms, And if they had fever, cough, and the other symptoms that I put on in my slide, then they should self-isolate at home. Simple analgesia and to keep themselves hydrated. We knew that the viral load reduction will take place in 72 hours to 7 days. If they got better, then that was it. However, in 72 hours to 7 days. If they got better, then that was it. However, if they continued to have their fever, then they sought help from the GP N.H.S helplines. And if they needed hospital admission, they went through the COVID accident and emergency centers in the hospitals in the UK. People who came with severe symptoms to the A&E department, especially with acute breathlessness, unrelenting fever, delirium, were admitted to hospital immediately to the COVID assessment unit. And they were assessed there to see whether they should be in a ward area or they should be transferred to intensive care. The majority of patients who were transferred to intensive care were patients with acute breathlessness and with low oxygen levels on admission. So initially, the treatment was supportive because we did not know or understand what medications needed to be utilized. They were monitored and COVID tested. Every patient who was admitted at that time was deemed to be COVID positive until proven otherwise. And if these patients in the ward area deteriorated, they were transferred to intensive care for assessment and respiratory support. The N.H.S continued to look at capacity building. Nightingale hospitals were put together in various cities in the United Kingdom, starting from London, Birmingham, Manchester, and now it's gone on to other areas as well. And these Nightingale hospitals were set up fairly rapidly. So by this time, the procurement of PPE had improved. The United Kingdom started making masks and PPE equipment in various centers where they converted their businesses to making the PPE. There are a lot of household groups as well who were making masks. Ventilators were churned out by a myriad of businesses in the Midlands. The hospitals now became designated areas for COVID and non-COVID. They were designated as red, COVID rich, COVID, non-COVID green, light, etc. And there was an amazing change to working patterns. Doctors were designated as teams. Thoracic surgeons were in intensive care units because surgery, non-essential surgery was stopped. Then we started doing virtual clinics, virtual multidisciplinary team meetings. And as a result of these virtual multidisciplinary team meetings, my understanding is that there were a lot of patients who were discussed, and the attendance at these multidisciplinary team meetings also was pretty high, which is an extremely interesting observation. And waiting list prioritization began to happen. Now, what were the lessons learned? We learned that supportive treatment was the way forward when the patients initially came to hospital. However, there has been an amazing amount of dissemination of knowledge which happened. And I believe that this is probably the only disease that I learned so much in such little time. We had literature from Italy stating that there was something different in the postmortems which were carried out, that there was endothelial dysfunction. the respiratory teams, the cardiothoracic teams in the United Kingdom who put patients on extracorporeal membrane oxygenation were very vocal about the poor outcomes. They lost about 50% of their patients. And when they had their postmortems done, they found that it wasn't an ARDS in the lungs, but there were lots of clots, diffuse thrombi in small vessels. So endothelial dysfunction was one of the things that we learned from this viral illness. And we also found that we had a cytokine storm in the early phases of the disease. And therefore, when they presented acutely ill, it was a cytokine storm in the lung tissue which caused most of the problems. So we learned that cardiac disease, neurological symptoms with clots in the cerebral vessels, acute hepatic failure because of clots, musculoskeletal problems with disease in the peripheral limbs, and even hyperinflammation syndrome in pediatric patients. So what are the next steps? As we got better at understanding the disease, as we utilized a lot of the literature which came through, we felt that we now needed to lift the lockdown. Economic resurgence need to happen. There should be a fine balance between protecting health and protecting the economy of the country. So this lockdown was lifted. However, face coverings became mandatory outdoors. People were still requested to work from home, and there were new ways of working which began to happen. So during all this time, several centers were carrying out clinical trials, and the most important, in my opinion, was a recovery trial from Oxford, where they found that using dexamethasone to reduce cytokine storm early in the process reduced stay in intensive care. We also started using high flow oxygenation and prevent people going into intensive care for intermittent positive pressure ventilation. We also started using antithrombotics, heparin and enoxaparin, to counter the endothelial dysfunction to prevent the clot formation. So now we had some idea as to what to do, is to introduce dexamethasone early in a subset of patients, to introduce antithrombotics, and also some of the stuff which is coming out by way of research with immune-based therapy and plasma therapy, but all of these patients were put in trials. So now we felt that we had things under control, and now we're beginning to see the second surge. And in this second surge, we've got to look at the recovery team. We have some criteria to fulfill. Do we have the space, the theater and ICU capacity? We've got the impending winter. We normally have a winter problem in the United Kingdom. So with the flu, so do we have the availability of the entire team, the equipment and drugs? And we need to quickly have some more pathways and prevent infection. So we've gone back to the same priority levels from 1 to 4. And we've also identified risks. During this period of 4 to 5 months, we found that patients with asthma and chronic lung disease don't do very well. Diabetics, people with cardiac conditions, chronic kidney disease, severe obesity, above the age of 65, and immunocompromised patients, the overall results were not very good. The other group who also were affected badly were patients who are British Asian and of multiple and of ethnic minorities. So, how do we prioritize the recovery? I'm indebted to Nigel Mercer for giving me these slides now. The FSSA had looked very carefully and found in the PubMed search that there was only one paper which addressed making priority decisions. And that is from the Medical Journal of Australia, where they looked at waiting lists and elective surgery. And since they are a public-private delivery system, they could do this only in certain states in Australia. Then there was a joint statement, a roadmap for resuming elective surgery after the pandemic from the American College of Surgeons, the ASA, and the American Hospital Association. So all of these things are available with the MENT scoring system, which is again from the United States, which we felt that we should start looking at to arrive at some way of prioritization. So now, what is the size of the problem in the United Kingdom? How many patients were waiting for surgery before the crisis? You know, we just finished our winter problems and we were coming into early spring when the pandemic hit us. So waiting lists were already there. We probably have a couple of million patients now waiting on the list, but how many have since been added in the last 6 months? How do we prioritize these patients now? What do we tell them? What resources are available locally to deliver the surgery, especially high dependency unit beds and intensive care unit beds? What we have done in the UK is to terrify people. We have been extremely good at terrifying the population. And most of them have adhered to all the rules and regulations which the government have put to them. But we have a small proportion of the population which are probably fed up and are beginning to rebel a bit in various cities. And this really are the younger population who, I'm afraid, are frustrated because most of them have lost jobs and some of them are in university and they have not been able to commence into full-time education this year. So how do we manage all this? How do we manage the media? How do we manage the public expectation? This is a huge conundrum. So on the 1st of October, the FSSA, along with the colleges, have extended the priority level. Now we have priority level 5 and priority level 6. Priority level 5 is when the patient requests to remain on the waiting list, but to defer his or her treatment only because of their concerns regarding COVID-19. Now, this, if you like, has been another problem in the United Kingdom, where patients do not wish to come into hospital because they feel that they may fall ill with COVID. And as a result, they are not presenting to their primary care physicians with any of the symptoms which normally would have come to their notice. Cancer treatments, the procedures which would have been done by way of transplants have all been postponed. So these patients will remain visible and they will be reviewed by the teams to make sure that their own preference has not changed or the stage of their disease has not changed. This is difficult. However, this is one of the ways that we think that we could move forward. The priority level 6 are patients who have been offered 2 dates for treatment and have declined for non-COVID reasons, but still wish to remain on the waiting list. So the immediate future for us in the United Kingdom is to complete our waiting list review. This will happen at trust level, and this will happen at specialty level in the trust. Now, monthly updates to this guide, which I understand has been put forward to NICE. However, this will not be a mandatory guideline, but this is until such time as we get over the COVID crisis. The clinical review of patients in every priority must continue, and we need to reprioritize these cases as and when we think it is necessary. Finally, we have a post-COVID recovery problem. We've seen that the patients who recover and go home still have a lot of complaints, especially with musculoskeletal problems, with ongoing breathlessness. So a rehabilitation service has been started. Initial assessment is done at the time of discharge, and at 4 weeks, they're seen after personalized aftercare with physiotherapy. The regular follow-up is to be carried out by primary care for at least a year. And this service includes medical personnel, nurses, physiotherapists, and mental health, which is again a huge area which I have not touched at all on. Now, this, if you like, is going to be led by the Leicester Biomedical Research Center, which is a NIHR project, and they hope to recruit 30,000 patients. I'd like to finish here by acknowledging N.H.S. England, Nigel Mercer for giving me some of the information, Derek Alderson and Mike Griffin and my mate Rowan Parks for giving me all the advice to put this together, and the Surgical Specialist Associations. I thank Pawan, Ishwar, and Raman for giving me the opportunity to share our experience in the UK and the guidance that we are carrying out at the present time. Thank you.
Thank you, Mr. Pala Rajesh. It is really fascinating to listen to you, especially regarding the COVID-19, how it impacted the surgical training and practice in UK. Interestingly, if you see the three major minimal access associations in India, N.H.S, N.H.S, and also CELSI came together on the same note and a war footing, and we sit together and we drafted our own surgery guidelines, and we implemented, even presented in our JMAS journal recently. So I think we are all having something, and we have a lot of learning experience. I think COVID, even though it affected, and there are a lot of learning, I think the virtual platform, as you say, the learning has improved. Actually, I'm sitting on average of 4 hours a day trying to improve our academics. You have more time and less travel. So that gives you the extra luxury of